Dear friends and colleagues, today my talk is about holistic approach and management for complicated Epiphora with intense pulse-like treatment and endoscopic lacrimal surgery. For my current concept that I use for approach for the complicated tearing problem, the first part I would like to share about the surgical concept, and the second part I would like to share the concept of apply optimal treatment for severe ocular surface disease caused functional epiphora. On the right hand side, we show my ideal lacrimal ostium. First, the finding after endoscopic DCR. For the mechanism of the fail after endoscopic DCR, mostly the mechanism from the inadequate bony ostium removal and poor flap approximation. On the video, show the surgeon how to remove the bone only from the lower two-thirds, but did not for the upper one-third, and sometimes remove too much of the nasal mucosa. After put the silicone stent, for a while after the healing process, scar tissue encroaching from the upper part and the lower part like a stalactite and stalagmite phenomenon. Finally, the sum syndrome happened, and we can see very small ostium opening over the area of the common canaliculi, and sometimes the thick scar tissue happen. For the revision of the sum syndrome, we apply the vertical cut, and then we can see the very good internal lacrimal mucosa lining, and then with the simple posterior flap suturing with 6O YQ simple suture can correct this condition easily. The finding of the failure from the external DCR. For the video, show the surgeon try remove the frontal process only the lower two-thirds. By the endoscopic view, show the bony ostium is too small, and the surgeon try to enlarge. By the external approach, the limitation is we could not remove the bone underneath the medial canthal ligament, and sometimes if the surgeon remove the bone not adequately, it leading to the failed external DCR. When we remove the silicone stent, the total blockage happens. By the endoscopic approach, allow the surgeon performing removal of the bone over the upper one-third easily and adequately, especially the bone underneath the medial canthal ligament. For the simple technique that we use, the simple chisel and the mallet performing remove the bone adequately and conservatively. In this video, show complicated epiphora after multiple failed external DCR. By endoscopic view, we can see very small nasal ostium, and partially of the water could be passed by the lacrimal side linking. Intraoperatively, we can check the adequacy of the bone by 45-degree test that show inadequate bony removal. After removal of the scar tissue and the bone, especially on the upper one-third, could be removed. After vertical incision, we can see the anterior and the posterior flap. In this technique, we try to rotate anterior flap anteriorly and try to approximate the anterior flap with the nasal mucosa anteriorly with the simple flap suturing with the two simple 6OYQ flap suturing. In this technique, we can perform flap approximation with the primary intention healing, and after that, inject the steroid and perform the silicone stent with the gel form. For the thick scar tissue at the common canaliculi, in this case, it's very challenging for performing the revision surgery. After removal, the very thick scar tissue at area of the body of the lacrimal sac, we can see that the previous surgeon did not remove the upper one-third of the bony part properly. So we have to remove the upper one-third of the frontal process of the maxillary bone. With the simple technique of the chisel and the mallet, we could remove the bone properly. After that, we can see the very thick scar tissue overlying the area of the common canaliculi. At that time, I got the very difficult time for lysis and remove the scar tissue at the area of the common canaliculi. At that moment, I try to create the horizontal incision and try to use the scar tissue imitate like a superior flap and try to rotate the pseudo superior flap superiorly and try to perform fixation of the superior flap to the nasal mucosa superiorly with the 6O YQ flap suturing. In this technique, I think we can try to fix the superior flap superiorly to the nasal mucosa and prevent the superior flap move downward and prevent the recurrence of the scar tissue. After that, the steroid injection and the silicone stent and the gel foam could be applied. For the second part of my talk is about the optimal treatment for the complicated functional epiphora caused by blepharitis. 44 years old lady with the problem of marked epiphora happened at 1 month after the successful endoscopic DCR on both sides. And when we do the mybography, we show that 80-90% of her meibomian gland have been lost. She has a marked facial rosacea, marked eyelid margin abnormality, and severe meibomian gland loss, and marked keratitis, and follicular and papillary conjunctivitis. All information initiate refracturing and complicated epiphora. Her eye is so red. Let's take a look how meibomian gland dysfunction happen. This is the normal eyelid, and the meibomian gland inside release the oily layer to be the outer layer of the tear film. Once they have the abnormal blood vessel encroaching and inflammatory substance release and the meibomian gland shrinkage, so they have the blockage of the outer layer of the tear film, so they have a lot of ocular surface inflammation. It is so worthwhile for the ophthalmologist and the lacrimal specialist to understand the cause and the optimal treatment for all causes of ocular surface disease. After 2015 and 16, there have many studies coming out regarding to the guideline recommended by the DUCE 2 guideline in 2017. They have 4 steps. Let's focus to the step 2. The concept of the treatment for the Demodex with the tea tree oil and in-office meibomian gland expansion. In 10-pound light treatment, the IPL initiate from the xenon fat light, initiate the broad spectrum of the light by above the 590 nanometer. The first mechanism, thrombosis of the abnormal blood vessel. Second, soften the obstructed meibum. Third, reduce the Demodex and the bacteria. Fourth, decrease the level of the pro-inflammatory mediator and inhibit the progression of the inflammation. 5. Restore the meibomian gland morphology and functionality. This is a study that showed that the meibomian gland acini had been better. The meibomian gland orifice is smaller and reducing the meibomian gland fibrosis, and the last follicle improved and the number of the Demodex have been reduced. This is showed my patient that got the before the IPL treatment. They show marked redness of the eyelid margin gland and a lot of the Demodex and the bacteria on the eyelashes. After 2 times, we can see the marked improvement by reducing the redness. After 9 times of the IPL, more improvement. After 15 times, they have marked reducing of the size of the abnormal blood vessel. On the left-hand side, before the IPL, the meibomian gland content is quite so turbid, and sometimes it like toothpaste-like content. And it's quite so difficult to express the content from the gland. And on the right hand side, after 6 times of the IPL, we can see that the content of the gland is more clear and more easier to get expressed. In this lady, she got the chronic off and on red eye and tearing and subconjunctival hemorrhage for the past 20 years. After the IPL for 16 times, we observed the microscope videography. It showed a marked improvement of the staining on the cornea and the marked improvement of the degree of the conjunctival callosis. Anterior blepharitis caused by Demodex and bacteria is one of the most common under diagnosis and the treatment. 5 to 10 years ago, the treatment started with the eyelid hygiene treatment with the tea tree oil. Even though the machine called BFX, we found that the Demodex is so stubborn. In the video on the right lower, show that immediately after the eyelid hygiene, we still could see the body of the Demodex lying underneath the skin in the hair follicle. Even though we tried the anti-parasite and the eyelid hygiene treatment with the tea tree oil, the study showed that the eradication remission rate of the Demodex is only 71.6%. Many studies confirm that the IPL helps to eradicate the Demodex and the bacteria faster. On the picture show only 2 times after the IPL, the Demodex could be eradicated completely. And one of the studies by Dr. Chang showed that the IPL increased the temperature about 54 Celsius or 58 Celsius, can completely eliminate the mite effectively. For the treatment protocol of the IPL that I have used currently in my practice, the first setting recommended by Dr. Toyos started from ear to ear, including the nose. For the second setting, performed for the upper and lower eyelid, include 2 classes and 3 to 4 shots per each eyelid, and then eyelid expression could be done accordingly. For the IPL, we can start from 4 treatments, 8 treatments, or 12 treatments or more, every 2 to 4 weeks, minimal discomfort, painless procedure or spa-like treatment. Then, after this achieve for 80 to 90% of the improvement, every 3 months or 6 months for the maintenance and prevention protocol would be recommended.